Hello friends, so today I'll be just talking about this drug sacubitril valsartan. It's a new drug which I'm sure many intensivists must have heard and maybe using, so cardiologists have been using. So I thought it's important we just touch about the salient aspects of this drug and the key aspects that every intensivist and every doctor needs to know about this drug. So basically sacubitril valsartan is a ARNI or angiotensin receptor neprilysin inhibitor. So basically, it has two important modes of action. So as we know, in a heart failure, the key detrimental aspect is activation of renin-angiotensin-aldosterone system. So this sacubitril, we'll call it as ARNI through the narrative, blocks the RAS. So by blocking the renin-angiotensin-aldosterone, there are these favorable molecules that increase in the circulation, which are endogenous vasopressors, which is good for heart failure, increase in the bradykinin and increase in the adrenomedullin. So these have favorable effects in the heart failure. Along with it, the most important aspect is it blocks a molecule called neprilysin. Neprilysin is a molecule that causes degradation of natriuretic peptide. So in heart failure, we need to have more of this natriuretic peptide, as the name suggests, for the natriuresis and the water content to be eliminated. Because this neprilysin, which is ordinarily present in the heart failure, it sort of depletes this natriuretic peptide by destroying this. So sacubitril or ARNI blocks this neprilysin. But the trade-off of doing these two, it increases the angiotensin 2. We know that angiotensin 2 is not good. That is why sacubitril is combined with valsartan, so that valsartan is an angiotensin receptor blocker. This angiotensin 2 effect is blocked by the angiotensin. That's why it's given as a combination. The reason they have derived at this combination is because of studies with the precursor molecules. So the first drug that came out was omapatrilar. So this was the first agent which looked at blocking this neprilysin. But this had a lot of adverse events. This omapatrilar inhibited neprilysin, inhibited ACE, and then it inhibited aminopeptidase P. So it inhibited all these three. So what happened as a result of this? Because there was increase in the ACE levels, there was a lot of angioedema. Okay, and there was overtly increased levels of bradykinin. And all these three agents, neprilysin, ACE, and aminopeptidase, are involved in degradation of bradykinin. Okay, so because it is inhibiting all this, degradation of bradykinin is not happening and angioedema is increasing. So this agent had to be abandoned. So this was the sort of a molecule which was considered prior to development of this sacubitril. So that's why they learned and they had to combine it with valsartan to block the angiotensin 2. Otherwise, they had huge issues with angioedema. So after this, there was another molecule which came called as ecodotril. So this was also neprilysin inhibitor. So as you see, the science evolved with development of a neprilysin inhibitor. But what they found is neprilysin inhibitor increased the ACE levels, increased the angioedema. So that's why they had to combine it with valsartan to block the angiotensin 2 activity. And this particular drug, when they used, it was shown to have no benefit in heart failure. And again, the increase in natriuretic peptide, which is good, was offset by increase in the angiotensin 2. So obviously, this did not have combination of ARB, angiotensin receptor blocker. So it did not have any benefit in heart failure. Okay. And in fact, because of increase in angiotensin 2, the studies showed it had deleterious effects in the heart failure. And the another molecule that came was nesiritide, which was also similar to this. It was a B-type natriuretic peptide. So that also had this problem of the same. And this particular drug was not proven to be successful even in the study called ASCEND heart failure study. Okay. So these were some of the studies where they have looked at whether sacubitril or ARNI causes any angioedema. So there was this study called paradigm heart failure study where they compared the occurrence of angioedema between the ARNI, angiotensin receptor this inhibitor, and ACE, and they found that there was only nominal increase in the angioedema with ARNI. And Pioneer Heart Failure is another landmark study where they compared the occurrence of angioedema between ARNI, angiotensin receptor neprilysin inhibitor, and ACE. It was 0.2% in ARNI and 1.4% in ACE, which means to say the occurrence of angioedema was significantly less with ARNI. So that was an important aspect. So, so what are the reasons that ARNI has a favorable benefit in heart failure? So, the possible mechanism is there is a greater reduction in the blood pressure with the use of ARNI, and these are the studies. These are all landmark studies: Paradigm Heart Failure and Evaluate Heart Failure study. And there was a decreased diuretic requirement because there was increase in the natriuretic peptide, and there was a good natriuresis that was happening. So the need for diuretics was less in heart failure with the use of this drug ARNI. And there was a reverse remodeling in patients with heart failure with reduced ejection fraction. So these were the three important components which conferred benefit in heart failure: greater blood pressure reduction, which is good for heart failure, and reduced need for diuretics, which is good, and there was a reversing of the remodeling, which is also very important in heart failure. All these three were achieved with ARNI. So this was a study where they compared ARNI versus enalapril. So this was a evaluate heart failure study. This was a short study done over 12 weeks. So they did in 464 patients comparing ARNI and enalapril, and they checked the aortic impedance and the ejection fraction. So the effect was similar between these two groups. And but what they found significantly is in the patients who were getting ARNI, the left atrial and left ventricular volume reduction was much better, which means the filling pressure or whatever you would call was significantly less in ARNI group. So which obviously has a much favorable benefit in heart failure. And another important thing I think the listeners should appreciate with the use of ARNI is ARNI users had a beneficial effects on renal functions and glycemic control. So this is a additional advantage they found, especially diabetics who are at a higher risk of developing heart failure. This had a much more enhanced advantage in having better glycemic control with the use of ARNI. So this was a distinctly additive benefit they found with ARNI, and they found in rat models ARNI reduces significantly the proteinuria also. So they did a secondary analysis of this paradigm heart failure study, and they found they checked at the GFR, estimated GFR between ARNI and enalapril. So the patients in the ARNI group had a slower decline in the estimated GFR, glomerular filtration rate, and they looked at HbA1c at 1 year in the ARNI group, and the HbA1c reduction was much lesser in ARNI group as compared to the enalapril, which means it had an additional glycemic control. It had a beneficial effect in achieving better glycemic control in heart failure studies, especially the ones with diabetes. So this was an additive, distinctive advantage over other ACE inhibitors. And they looked at new insulin usage in patients with diabetics with heart failure, and the new insulin usage was significantly less in the ARNI users as compared to enalapril. So this is an additional advantage along with the other advantages of reversing remodeling and reducing blood pressure and reducing the diuretic need. This was a new additive advantage which they found with ARNI compared to the other ACE inhibitors. So the dosage is it's a little tricky to remember. So the easiest way to remember is, so you have 50 mg, 100 mg, 200 mg. When you talk about a 50 mg of ARNI or sacubitril valsartan, it contains 24 mg of sacubitril and 26 mg of valsartan. So it may be difficult for us to remember this. So if you say 100 mg of say Vymada, the molecule name, the originator molecule name, it contains 49 milligram of sacubitril and 51 milligram of valsartan. So 200 mg, if we give, it contains around 97 and 100. So I think the easiest for us to remember is 50, 100, 200, and it would be, I would say the easiest way to remember is 50-50 of each. You know, if it is 50, then you split it into two, so 25 milligram of each. 100 means 50 milligram of each. 200 means 100 milligram of sacubitril valsartan. I think that is the easiest way, because I don't think I would expect anyone to remember 97 mg of sacubitril and 103 mg of valsartan. So that would be the easiest way for us to remember. So is there any dose adjustment in renal impairment? So if estimated GFR is more than 30 ml, there is no dosage requirement needed. And if estimated GFR is less than 30 ml per minute, then the suggested dosage is 50 mg every day. So as you see, sacubitril twice daily. So we can go up to 100 mg as maximum. So maximum is 200 mg. So in hepatic impairment also it is very similar. Mild impairment, no dosage needed, no dosage adjustment. But if it is a child C cirrhosis, again it is 50 mg twice a daily. So is a dose that you could give. So that is in a very brief. So that is all I'm going to talk. So one thing is the mechanism of action and how it has had a beneficial effect in the heart failure is what we understood. And the risk of angioedema was significantly less even when compared to enalapril. And the third unique and distinct advantage is with the additive hypoglycemic control and less need of needing insulin. So these were, and reducing the proteinuria also to some extent. So these were the distinct advantages of this sacubitril valsartan or ARNI, angiotensin receptor neprilysin inhibitor. So thank you all.